So as promised, we're now going to talk about managing those cardiovascular risk factors, and I think that also, again, I'm not going to be providing you with a whole lot of new information about how to actually, about what cardiovascular risk factors pathophysiologically do, okay? But what I'm going to be doing is providing you with skills so that you can communicate the knowledge and information that you have to the patient so that it actually empowers them to self-manage. As you and I all know, diabetes causes microvascular disease. It causes blindness, peripheral neuropathy, erectile dysfunction, I've already said blindness, renal disease. We also all know that diabetes is highly associated with macrovascular disease, heart attacks and strokes. And because of that, we know that as providers, we need to then go and look at what other chronic diseases they have got that are also going to contribute to their cardiovascular risk and minimize their cardiovascular risk, such as in cholesterol, lower it, and blood pressure. And so, for those of you who are providers, when you show up on that busy afternoon clinic and you look at the middle of the afternoon and find that you've got a diabetes review appointment there, I know that many of you, your heart will sink, because you know that in that 15 minutes you've got with the patient, you're supposed to be reviewing their bloods, looking at whether or not their HbA1c is appropriate, making a decision as to whether or not you need to escalate medications. If you are deciding that you need to escalate their medical management, then you probably need to go and have a look at the blood sugars, which you hope they've jolly well brought with them. And then, of course, there's that blood pressure you need to look at and decide whether or not you need to change the blood pressure medication. Did you actually send them off for retinal screening? Did they forget to go? When was the last time you did it? Have you checked their urine for protein? Are they on an ACE? Are they taking... The list is endless. And for many of you, I think that that diabetes checkup appointment can be incredibly overwhelming, if not incredibly disappointing. You often come out of it feeling like you only checked half the boxes that Chris Hermanson would have liked you to have checked. And not only that, your patient isn't doing any better than they were a year ago. So hopefully in the next 20-25 minutes, I'm going to give you a little bit of light at the end of the tunnel, so that in fact we can turn that 15-minute appointment in the middle of your busy afternoon into the lull in the middle of the storm that you've got, as opposed to that frantic, horrible 15-minute appointment. So what is the trick? Well, it's not really a trick that I'm going to offer you. What I'm going to suggest to you is that you forget about those boxes that you're supposed to be ticking. Sorry, Chris. And I'm going to... I'm going to ask that actually you gather that patient up. You take a step back and gather that patient up and then bring them along with you and share with them the knowledge that you are using in that appointment. And as soon as you do that, remarkably, you will find that the person is totally on board, and actually there's not a whole lot that you need to do during that 15-minute appointment. As many of you know, I run a diabetes service, or I've mentioned before, I run a diabetes service in New Zealand where I have people who are referred to me for their diabetes management. I am very fortunate, I'm very lucky to have such a setup where I can spend time with them looking at their diabetes management. But after we've spent time going through their pathophysiology and all the different obvious choices that they can make for managing their diabetes, and then we get them on the road, I then take a step back and I say to the patient, so why are we spending all this time caring about your blood sugars? Why do we have to control your blood sugars? And most of them will look at me and they'll go, oh, well, if I don't take care of my blood sugars, I'm going to go blind, or I'm going to get my feet cut off, or I'm going to end up on renal dialysis. And I go, yeah, sure, okay. They got that bit right, okay? But why? Have you ever actually thought about what it is about diabetes that's going to affect your eye, but it also affects something down at the other end of your body? What is it about diabetes? Have any of you thought about that? I think probably most of us have a pretty good idea. And so I take the person back. Remember when we talked about your HbA1c when we were talking about diabetes? We talked about the fact that in your blood vessels you have all of these things floating around, such as your red blood cells and all of your immune system and your magnesium and your phosphorus and your potassium and, of course, all your sugars because of the energy supply that we need. Remember we talked about the fact that the sugars stick on the outside of the red blood cells And this is what we actually measure when we're measuring for your HbA1c. Well, the sugars don't just stick on the outside of the red blood cells. They also stick on the inside of the blood vessels. And when they stick on the inside of the blood vessels, they cause chemical reactions and inflammation and end up damaging all of the blood vessels. And that's all fine in the big blood vessels because we don't really notice it. They manage to cope pretty well. But you can imagine when you've got a little blood vessel that things happen to be a little bit different. And when all those sugars stick on the outside, we end up with a bit of a problem, and the red blood cells can no longer float along the little tiny blood vessel. Where do we have the little tiny blood vessels in our body? They go in our eyes, and in our toes, and in our kidneys, and in our penis, the one that they never want to bring up, okay? And that is why diabetes affects all of those parts of our body. You can bet that after you have taken a minute, maybe 2 minutes to draw this picture on a paper towel in your office, as I did in Quarryville as a resident, after you've taken that 2 minutes, you can bet your bottom dollar that that person is going to show up at their next retinal screening because they want to know what's going on with their blood vessels in the back of their eye. And you can bet at their next appointment with you, they're going to show up and the first thing they're going to do when they walk in the door is go, so what were the results of my retinal screen? What do my blood vessels look like? Okay, so providing them with the information provides you with the empowered person who's going to self-manage. Similarly, with cardiovascular disease, I do a sort of a similar kind of approach. And again, slight half apology, I'm not providing you with any new information. I'm just sharing with you what I do with a person to share with them the information to empower them. I generally start off this whole topic by saying, you know, your primary care physician sends you off for blood work every 3 months or so. Do you have any idea what he or she is looking for? I have to tell you, the vast majority look at me completely blankly. It's a relatively small percentage who might come up with, I think there's a fasting cholesterol in there. It is even less common for somebody to come up with, I think they're looking at what my average blood sugars are over a period of time. And I go, yeah, those are a couple of things that we're looking at. In fact, there's a whole slew of things that your doctor is trying to do, and I'd like to go over those with you because I think it's incredibly important that you understand. You know, we've just talked about the fact that diabetes damages the little tiny blood vessels in your body. And where do you have little tiny blood vessels but on your heart? And so diabetes is a cardiovascular risk. It's a risk to your heart. It's a stress to your heart. And so what your doctor would like to do is look at all the other things that are a stress on your heart, that are taxing your heart. And we'd like to minimize that risk. And so we have a total of 5 things that we look at every time you come into that appointment. We're looking at your diabetes. We're looking at your smoking and whether or not you smoke. We're looking at whether or not you have high blood pressure. We're looking at whether or not you have high cholesterol. And we're looking at whether or not you're obese. And for each one of these, we have a gold standard that we are aiming for. Now, we have just spent some considerable amount of time looking at your diabetes to see whether or not we are hitting your gold standard. And the way that we have done that and helped you to understand it, of course, is we've gone through the whole explanation of what your HbA1c is for that gold standard. I remind them of the fact that we reviewed the idea, and we've certainly done this together, the idea that if you lower a person's HbA1c by 1 percentage point, you will bring about a 27% reduction in their risk of a heart attack or a stroke within the next year. And that's true of any percentage point that you drop them down. And I'm not going to kind of go into this in any detail because I know we've done this in a previous talk. I am, however, going to emphasize the fact that, yes, an HbA1c is a measure of an average blood sugar. However, a far more important reason, and the reason why you as providers check an HbA1c, is because it is a very strong predictor of what their risk of having a heart attack or a stroke is. I'm going to repeat that because very few of you got that right in the test. An HbA1c is our cardiovascular risk predictor. Okay? So once I've refreshed the memory of the patient about the HbA1c, I go back to their little chart and I say, when you first came to see me, your HbA1c was 11.1%. I'm very lucky I have a point of care DCA analyzer where I can do an on-the-spot HbA1c. I highly recommend you get one, because we then very quickly go and do one and say, hey, look, in a month you have brought your HbA1c down to 9.4%. Fantastic. Imagine what it's going to be like in 3 months when you go for that next 3-month check. So we're getting closer to that gold standard that we're aiming for, and this is the magic number if we're trying to minimize your risk of having a heart attack or a stroke. What about smoking? We sit there and we tell people that they shouldn't smoke. What is it about smoking? Why do we keep going on about that? Well, smoking does very similar stuff as does the diabetes. It damages the blood vessels, and so you can imagine that it also damages the little tiny blood vessels. So when you're a smoker and you've got diabetes, you've got a double whammy going on, and you're going to have a bit more of a problem with all of those tiny blood vessels. And if I've got a guy in the room, I will particularly emphasize erectile dysfunction, and this may well be when I bring up the subject with them, because it really brings it home. In fact, I think it's really unfortunate that we don't bring this up even with our people who don't have diabetes, our young men who are starting smoking, because I think if they understood that by the age of 40 they were going to have a problem with their erection, they might think about it again. All right? So we go back to the personal sheet that I create for them, and we add in their smoking status. It would be a good idea if we started to think about it. I don't necessarily go into it during this appointment, and truthfully, again, I can do this in a 15-minute appointment, but it gives them something to think about so that when we bring it up again, they understand where it fits in the big picture. When I talk to you on Friday and I talk about empowerment, I will be talking about how you talk about smoking cessation, all right? Blood pressure. What is it about blood pressure that is a problem for people who've got diabetes? So I say to the person, when we take your blood pressure, when you first arrived here, it was 146/98. Do you understand what those two numbers mean? You know, when somebody puts their cuff around you and they say, oh, your blood pressure is 128/84, do you actually understand what those numbers mean? I tell you, not one patient has ever been able to say, yeah, of course I do. In fact, I wonder how many of us in this room truly understand what's going on, and so I think it's worth explaining to them. So our heart, I tell them, is like this big muscle in our chest wall. They all kind of know that. And when it squeezes, it's a hollow muscle, so when it squeezes, it shoots the blood out. It shoots the blood out so it can go all the way around our body. And then, of course, it relaxes, and when it relaxes, it can fill up with blood. When it squeezes and shoots that blood out, we can measure the pressure that it creates in the blood vessels. That is the top number, and we measure it the same way as we measure barometric pressure in the weather, in millimeters of mercury. So when the heart squeezes, when a healthy heart squeezes and shoots that blood out, the pressure that we expect to get is somewhere around 120. The heart then relaxes, and it's filling up with blood, and when it relaxes, we can measure the pressure in the blood vessels, and we get a number somewhere around an 80. They're fascinated. It's pretty logical. It's incredibly simple. It's much easier to understand than a cell phone and how to operate a cell phone. Okay? Well, let's say something happens, and for some reason that heart has to work really hard to squeeze the blood out. And when a muscle works hard to squeeze the blood out, it's going to shoot that blood out at a higher number, right? Maybe at a 146. But when that heart has to keep doing it and work really hard, like any other muscle in our body, it's going to get bigger. It's going to get thicker. Unfortunately, when it gets thicker, it gets stiffer. So now we've got a big heart that's shooting this blood out, and when it goes to relax, it can't relax very well. So it can't fill up with blood very well. Which means, guess what? It's going to have to pump faster because it's got to get the same amount of blood around the body in the same amount of time. So you end up with a very big heart that's pumping faster, and you end up with an increased pressure because it's not relaxing, and that is the bottom number. Now, normal blood pressure is 120/80. Your blood pressure is 146/98. What do you think your heart's doing in there? Do you think that motivates them to take their blood pressure pills? That's not what I'm really about. What I'm really about is hoping that when I send them back to their primary care physician and their doctor takes their blood pressure and the doctor sits there and goes, not bad, not bad, that the patient's actually going to sit there and go, well, what is it? What is my blood pressure? Oh, sorry, sometimes I go through and I explain to them about the different stages of high blood pressure. But they go, so what is my blood pressure? And the doc might go, well, it's 138/84. And the patient, what I'm hoping they'll say is, 138/84, that's not good enough. What are you going to do about it? What are we going to do about it? In other words, the patient is empowered and would like to change things. Okay, makes sense? And so you stick their blood pressure in there with it. I often also go through their medications at this point. What are you taking for your blood pressure? You might be on a beta blocker or a calcium channel blocker. I will write them down next to where we're talking about so they understand which medicines are associated with it. Okay, so I'm giving them all the information they need. Cholesterol, you and I will know what cholesterol does to contribute to cardiovascular risk. I encourage you to find an absolutely fantastic handout for this. This one is actually produced by the company that produces Lipitor. I'm sure it must be available over here. Okay, and when you open it up, it has absolutely fantastic pictures that you can point to people, not only to point out the idea that cholesterol clutters up the blood vessels, makes them very small, so of course naturally, and they can imagine this, naturally means that the heart is going to have to squeeze harder in order to get the blood to go through, but it also paints a lovely picture of what a plaque is, and also goes through what LDL and HDL and all the different cholesterols are and provide them with their different values. And people actually really understand this very, very well and get to understand why is it that it's LDL, the bad cholesterol, that we really do care about, and what can we do to get it down. So once again, having gone through that on the back of it, it has a nice thing about foods and good fats and bad fats. Oops, I didn't use those words. And then again, I will put where their cholesterol is, what their medications are that they are on, and you know what, maybe you're on 80 of simvastatin, maybe we should be switching you over to a atorvastatin, and explain to them what the different choices are that they can do. Obesity is another problem, of course, that we need to address as part of the cardiovascular risk, and I'm almost a little embarrassed to tell you what I say to the patient when I'm sharing with them how this contributes to the stress of the heart. Essentially what I say, and I suppose there's an element of truth in it, I hope there is an element of truth in it, is that if you're a little person, your heart doesn't have to work very hard to get the blood around you. But if you're a bigger person, then obviously your heart's going to have to work harder to get the blood around you, and most of them seem to buy that pretty well. Obviously, you and I know that there's an awful lot else about obesity that contributes to cardiovascular risk, and that there is this gold standard that we're aiming for in a person, as there are with all of the others. And again, hopefully, having just gone through the foods with them, they are now enthusiastic about trying to perhaps minimize their grams of carbohydrate in their meals. Truthfully, we find that if we leave obesity to the very end, it's something that they become very excited about when they've gotten to understand how to manage their blood sugars and all the other things, apart from the fact that they've now got energy because their blood sugars are normal. So those are the 5 cardiovascular risk factors that your doctor is looking at every time that you go in for your appointment. And the goal is to try and minimize each one of them so that we're getting closer and closer to the gold standard. Out of those 5 cardiovascular risk factors, there is one that is especially important when it comes to thinking about your heart. And that, of course, is this one. And of all these things, the most important thing for a person to control or for a person to take care of is their blood pressure. And that's why I so want them to be able to feel empowered enough to go into their own doctor's appointment and say, what was my blood pressure? And that 138/84 is not good enough. Okay, we've actually had to do a lot of provider education to allow the patients to be able to do that. Okay, I can't encourage you enough to also work on that side of things. We go on from explaining these 5 cardiovascular risks to then saying we also have ways of protecting your heart and of protecting your kidney. I'm also a little bit slightly embarrassed about what I tell people about why we prescribe aspirin, but we think of aspirin as thinning the blood. And you can imagine that if we've thinned the blood, it's a little easier for the heart to get the blood around. Again, it's a little bit of an exaggeration or a simplification of what it does, but again, it's good enough for them to understand. I go through the current recommendations of aspirin because at the moment there are a lot of people who are on it that should not be on it. To remind you guys, the current recommendation of the American Diabetes Association is that people who have diabetes, and it's all they've got, and they've got diabetes and high blood pressure and a few things like that, we do not recommend that you prescribe aspirin. The risks of a bleed for long-term aspirin use in somebody who's got diabetes far outweighs the benefits. If you've got a person who's got diabetes and a significant other microvascular event, such as a heart attack, a history of a heart attack or a stroke, ischemic heart disease or peripheral vascular disease, then it is recommended that you put them on an aspirin. Okay, and I review that with people because often they come into the office and they are on an aspirin and they don't need to be, as this patient didn't need to be because they had not had a heart attack or a stroke. They like you if you tell them that they don't need to be on something that they are already on. I then finally point out how we can protect their kidneys. Most of them don't have any idea about how diabetes or high blood pressure for that matter damages their kidneys. And so the way I explain it to them is, you know, your kidneys are like a sieve. Every time your heart pumps the blood around, the blood goes through the kidneys and the kidneys sieve that blood. It lets out all the bad stuff into the urine and sucks all the good stuff back up into your blood. They can understand that. Okay? Unfortunately, the high sugars and high blood pressure damage that sieve and make the holes kind of big so that the sieve leaks. And so if you have high blood sugars or high blood pressure for a period of time, you end up with things leaking in your urine. Has your doctor ever sent you off to pee in a cup? And they go, oh yeah, I was wondering what they were doing. Well, they're looking at your urine to see what's leaking in it. They think it's kind of funny, actually. And I go, and what we're looking for is protein. And if they find some protein in your urine, then we know that you have got a kidney that leaks. Okay? Once you have got that leaking happening, we know that the damage has begun. Now, that is not all bad news, I say to them. The good news is that we have the ability to absolutely stop that from progressing, or we have the ability of slowing that progression down. We can do three things. The first one, of course, is we can control your diabetes, which we've spent a lot of time talking about. We can also control your blood pressure. It's really important. In fact, out of those two things, once again, the most important thing to control is your blood pressure, not your diabetes. There's a third thing that we can offer you, which is an ACE or an ARB, so that we can help to prevent the progression of the damage to the kidneys. There is absolutely no evidence to place a person on an ACE or an ARB if they do not have any microalbuminuria. None of your patients who do not have microalbuminuria should be on an ACE or an ARB unless you're using that for blood pressure control. The only time that we have evidence for using an ACE or an ARB for renal protection is if they have already started leaking protein into their urine. And of course, current recommendations are that you should be pushing the ACE or the ARB to maximal dose for maximal protection. Okay? And so I circle for this person, oh, that's gone misplaced. It should have been over by the no. So none of this is really rocket science. There is no trick about this at all. All I'm suggesting is that if you take that patient in hand and if you take them and put them in the big picture, just like you and I are, and share with them the knowledge that you've got in a way that they can understand, then you're going to actually find that that 15-minute appointment in the middle of your busy afternoon turns into one of your most enjoyable appointments. Most of my diabetes follow-up appointments with my patients in my general practice take about 8 minutes. I've timed them because they've already self-managed their own blood sugars. They know what they want to do around their blood pressures. They've done their retinal screening because they understand the importance of it. it, they've filled their medications because they understand the importance of it. I can only urge you to take a step back and bring your patients along too. Thanks very much.